Okay, everyone. Welcome back to seminar for the winter and spring 2024 term and a half. My name is Jackie, and I am helping co-moderate the seminar this term with Steph Ross and Michael Bagley. And our first presenter of this term is Evan Coopes, who's joining us from Curtin University in Australia.
Perth, yeah.
Perth.
Yeah.
And Evan has a Bachelor of Physical Education from the University of Western Australia, as well as a Bachelor of Science in Physiotherapy from Curtin University, and is currently a musculoskeletal and sport and exercise physiotherapist. And he's been practicing 30 years of physiotherapy clinical practice in the domains of orthopedic, musculoskeletal, and sports physiotherapy, including 20 years of teaching and the staff role in the School of Allied Health at Curtin University. He's principally focused on teaching both at the entry level and graduate level physio and postgraduate courses, as well as some supervision and curriculum development. Some of his current research interests are some clinical reasoning at the entry level of physiotherapy practice and translation of research into contemporary clinical practice. So I'll hand it over to Evan, and thanks for joining us today.
Thank you. Yeah. Does everyone can hear me okay? Thank you for having me along. First of all, I'm trying to see how many familiar faces there are out there in terms of who we've met, but just scary room of people here of unfamiliar faces. Just on behalf of my colleagues, Angie and Carly down the back, I just got to can't thank the School of Kinesiology here enough and the staff for the incredibly warm, generous welcome that we've had. We've got a further week here and hopefully might get a chance to meet a few of you in the room. And thanks for asking me along. I've prepared a presentation based around some of the material I would teach to some postgraduate students, or postgraduate PT students at Curtin. And I hope you'll find something of value in there. A couple of things here. Am I allowed to wander around the room? Because I tend to wander. I tend to terrify the students I teach, because I'll often be wandering around and suddenly they'll have me sitting next to them. Do your profs do that too? Yeah, is that okay if I do? And if I were to stick a microphone in front of you, would you be kind of cool with that? Yeah. Anyway, so but if that's not cool, please just say. A couple of the quick things here too, and I'm mindful of the time that we have. Can I just get a quick show of hands? Who are the biomechanics people here? Who are the biomech folks? So you're all kind of grad, PhD, masters. Yep, cool. Who are the ex-phys folks here? Who works or has done or does work in sports med here? Are there any physios in the room? Apologies, I've got your back, but I might say some things that might upset you. Okay. Yeah, okay. And the rest of you obviously are other things. Okay, well, we'll see how we go. I was encouraged, she's going to share a little bit about kind of who I am. So if you can indulge me for a couple of minutes, and perhaps in so doing, try to paint a bit of a picture of life in Perth. So I'm a very fortunate, blessed, proud father of three beautiful daughters, all in healthcare. What else? My sporting passion is long course triathlon. I love showing this picture to my students at Curtin for a whole bunch of reasons. Kind of the contrast in human performance and capacity that we have. Are there any triathletes in the room? Okay, you might know the lass here in the front here is Yvonne van Vlerken, whose list of achievements. I think she's actually recently retired, but there's very little she hasn't achieved in her domain. She has truly amongst the best in the world, and to be former world record holder in long course and one of a handful of female athletes still who've gone both under the 3-hour and under the 9-hour limit for your half and full Ironman, which is extraordinary. And this kind of moment in time picture where you also capture me, who is a very different athlete from that. And so just as a lovely contrast, I should add, she's literally just coming into the finishing chute. I'm just coming out to get my run started, and I'm thinking, oh shit, I've got 4.5 hours to go. Anyway, there you go. Just in terms of interesting contrast, weekend before we, or a few days before we flew in here, I was doing a race with my club mates there in 35 degrees Celsius. So the ex-phys folks and Carlia will know all kinds of things can go wrong when you're exercising in 35-degree heat, and then we fly into the polar vortex that you guys had. When I grow up, I'm going to become a rock star. We don't have any fans following us around the world yet, but this is the band I play with at home. Professionally, like many of you, I began my career as a kinesiology student, and I've been really fortunate to go on to, as Jackie was saying, don't need to recapitulate this, my role as a teaching professor, and I continue to work and have never stopped working as a physio. So I'm first and foremost this. And in my role, I kind of have the luxury of being able to stand on the shoulders of kind of folks such as yourself, who do the hard yards and the hard work in terms of research and answer questions and develop new knowledge and these sorts of things too. The best part of my job that Jackie also alluded to, I get to kind of teach into the grad space. And here I'll start to kind of get into our topic for the day. So big part of what is actually with grad, I do a lot of kind of anatomy, pathology, pathophys, and applied clinical sports science stuff for qualified physios who are specializing in MSK and sports and exercise PT. Who teaches here? Most of you, a lot of you, one of the best parts of our role is getting to throw hand grenades to students and kind of say, hey, catch this. And the reason I mention that, it's probably relevant to today in that as we get these kind of physios coming into our course, they've been out for probably 3 to 10 years. They've got lots of experience, but they've also perhaps gained some very kind of not always helpful ideas and understandings around things. And they're kind of coming in, also, you're kind of having to direct them towards what the evidence does actually say. And to illustrate this, well, who's ever been treated by a PT here, physio at some point? Anyway, so that's interesting. So just want to have a listen here to the following and think back to your anatomy studies for those who've done that. So this is John, the PT, who's about to demonstrate a manual technique. And he's gone silent, which is, I can fix that. Bear with me. He's describing a manipulative technique here of the sacroiliac joint. And we'll get students, our postgraduate students coming in, all very excited about kind of talking about things. For example, here a common would be in our lab saying, Evan, when I'm doing all my fancy assessments of the sacroiliac joint, I'm trying to look at what the hip bone's doing and palpating. Is it flared? Is there an up slip or a down slip and this kind of thing? I'm coming in there kind of going, stop right there. And your answer would be, when I go stop right there, would be the song. Stop right there would be followed by, and my point here I'll make, do you love me? Will you love me forever? And in just kind of highlighting, and Walter, you would agree here, our job here as academics is to ensure a broad education of our students. And in mind, my mission in life is to help our musical education of our students. So that song is from where? That song comes from which landmark album? Who was the artist? The artist, song, artist's album would be Meatloaf, Bat Out of Hell, paradise by the dashboard light. I mean, and there I illustrate my point perfectly there that, anyway, so what's that got to do here? Simply just to make this point that in my role, calling out BS is an important part of what I do. And perhaps with that whole SI joint thing in mind, if we come back to here, anatomically, physiologically, the idea that you can yank on a person's ankle and foot and achieve a manipulation or cavitation of the SI joint is just, as I say, weapons grade BS in so many ways. Okay, so just part of my role there, my recently graduated PT daughter was calling me one time. She works about 3 hours north and say, hey, Dad, my senior has taught me all these really, really cool techniques for the sacroiliac joint. And I palpate here and I get my patient doing this and that. And she had this silence on the line from me. And she said, oh, Dad, I can hear you not saying it's all BS, isn't it? And I said, yes, honey, it is. Yeah. So my PT colleague down the back there, if I've upset you there. But anyway, so in terms of with that in mind, with our postgraduate program, a key part of that kind of applied clinical, that kind of science that we do here is physios like to think they are very good at strength and conditioning. And I thought there might be a few more sports med people in the room, but in actual fact, they're not. Well, they overestimate their abilities in that space substantially. And I was going to ask any S&C people, strength and conditioning people or kinesiology people, have you ever come across a PT who likes to overcomplicate things? And I think the answer would tend to be yes. So key part of our role with my colleague is trying to bridge that gap and ensure that we actually have produced physios, sport and exercise physios, with well-developed S&C skills, who actually can kind of talk the language of and therefore work effectively with kind of other colleagues in that strength and conditioning space, particularly. All right. Okay, so that's kind of a bit of a background there. And the topic I want to perhaps get on to this idea is what we call idea of kind of segmental control. Particularly as it kind of relates to the injury space, and this idea that segmental control or the lack thereof can be common soil for kind of different forms of lower limb injury, both those that are traumatic in nature and maybe a traumatic injury as well. And we'll explore that. Okay, so I was kind of hoping there was a few, well, we'll see. Who's familiar here with the reasonably contemporary primary, secondary, tertiary injury prevention model? Yeah, it's a fairly model that we're using a lot more. It's getting evidence that suggests it's very valuable for some injuries, not all. We don't have that compelling evidence there yet. But basically kind of proposes this idea that primary injury prevention, usually at a whole group level, healthy athletes, dealing with kind of big ticket items relevant to all of us and all people and all athletes and so on. And perhaps if there's any strength and conditioning folks in the room, you would agree that highly developed physical qualities, for example, are an underpinning bedrock for a healthy athlete, an athlete who's going to perform well. Secondary prevention, a little bit different. Tertiary prevention actually is that kind of realm working with injured athletes. That's probably where most PTs or physios predominantly work in this space here. They're seeing athletes who come to see them who've actually sustained an injury of some kind. So prevention in this sense is trying to get them to where their risk of re-injury is substantially reduced and they're able to get back to both returning sport, but also being able to be a better athlete, to perform better at the end. And prevention of injury, of course, is the holy grail. Be it acute traumatic injury, be it overuse injury, and so on. But unfortunately, the reality is we're never going to get there. we're never going to be able to prevent injury from happening. Why do you think that might be? Why is injury prevention of all form an impossible task? Can you guys propose any reasons why?
Don't have all the requisite information. You want to prevent an injury, everything under the sun.
Because there's kind of potentially a lot of factors that feed into that. Any one athlete at any one point in time has a multitude of variables at play. And that's kind of exactly here. That is what we might call a web of determinants. It will be unique to each athlete, it will be unique to their sport, unique to the kind of type of injury. And an individual's web of determinants will vary across time as well for all kinds of reasons. For example, there's a few here who kind of work with menstrual cycle research, don't you? That's a variable that will be obviously is in a cyclic fashion changing all the time, because that's a anyways. And even if we look at, and like Pat's heard here, a lot of these variables are both difficult to control, hard to measure, and difficult to change or modify also. If we look at ACL injury, for example, no two ACL injuries are the same. And if you didn't know, and I think, Carla, you've done a lot of ACL stuff here, probably quite a bit. I think the number of ACL injuries at the Sports Med Clinic, Carla, you can correct me here, probably numbers in the thousands each year. Would that be right? So anyway, and we're going to look at ACL injury as an example here. All right. Point being, this web of determinants will be unique and variable to each person. So no two exact same injury type, pathology the same, but the whole context, background, web of determinants will be different from athlete to athlete. So I guess what we're saying here, we're still at a point where predicting injury risk is a bit like interpreting a crystal ball. We're getting there. We have some tools, but they're still quite blunt depending what injury type you are talking about. Okay. So perhaps we talk much more about trying to reduce injury risk profile. Recognize that we can never reduce injuries happening, but can we look at an athlete and can we look at things about them, identify different aspects of their web of determinants and try to reduce their risk profile? And in so doing, then we might start seeing in population terms, but broadly, injury numbers start to come down. I should add, anyone who's actually sustained an ACL injury themselves? Okay, just a warning, I know I've got some videos coming up of ACL injury and I kind of get it. These are yucky injuries, so there's a few videos. If you don't like those, just be warned about that. So we'll come back to now this idea of segmental controls, perhaps being one of that web of determinants for any injury type that maybe from a clinical point of view, we can identify, screen, and maybe do things about. Okay, all right. All good? Makes sense? Let's go. Please feel free to ask questions as we go along here. All right, so, and what we're trying to is kind of, with my physio teaching professional hat on, is what's the clinical relevance here? It's trying to ensure that the clinicians that I teach, they understand the etiology of different injury types to better understand and to inform prevention, both primary, secondary, and tertiary. Okay. And we're going to do a bit of a compare and contrast. So we image here. Here we're talking load magnitude, load frequency down. We're going to compare and contrast an acute moment in time, high energy impulse injury, like an ACL injury, non-contact ACL, with an atraumatic, perhaps cyclic loading injury, such as activity-related groin pain. All right, so all clear? Let's get underway. All right, so we'll start with non-contact ACL injury first of all. One of the most devastating injuries an athlete can sustain both short term. You're looking minimum 9 to 12 months out of your sport, and with potential significant longer term consequence in terms of the morbidity of the knee joint. The soccer players in the room will recognise this person just here. If you didn't know, probably Sam Kerr is just about the Prime Minister of Australia at the moment, given her profile. She sustained 2 weeks ago an ACL injury. Her coach described it as the following. She was doing something she has done literally tens of thousands of times. It was the most innocuous move. There was nothing particularly special about what Sam Kerr did. And I should add here, those that know this, as a professional who's been playing, well, she's been playing professionally since the age of 13. She's now 31-ish. How much at that level, how much injury prevention training do you reckon? How many hours do you reckon she would have done in that time? Bear in mind, she's probably has been up for the balloon d'or and just missed out about 8 times. Many, many thousands of hours of preventative work, including hours in the gym, strength and conditioning, balance training, landing training, all kinds of testing, screening. And you kind of, well, what did her web of determinants look like around the time of her injury? What was going on that made that motion, that task that she performed, that one-off time that she's literally done many, many thousands of times before, why did her ACL fail? So let's try to explore that question a bit here. Okay, so we'll start here. I'm going to show you, I had got lots of videos here of fancy athletes doing fancy things. I want you to look at the following 2 videos and ask yourself, what might be the defining, and the biomech people here probably have a bit of an advantage, what will be the defining characteristic of these athletes during these tasks? We'll start with Anthony Miller. First of all, excuse me, making his opponents look like complete numpties, which is what they're paid to do. That's why they get paid, because they're so good at making their opponents look like high school athletes. Now, Andrew, put this one in here especially for you. So he's just made 2 outstanding players look like complete fools, which is what he's got. He's got all kinds of gifts. He's got all his kind of physical qualities and awareness and endless training to refine that. I mean, that's just poetry. If you're a South African of descent, particularly. Okay, so thoughts, what would be perhaps the defining thinking here, perhaps with biomechanics particularly, what might be the defining characteristic? Any thoughts? No thoughts.
What are you asking? Defining characteristics of these 2 athletes?
So the question was, what's if there was, so we're talking here, thinking about non-contact ACL injury. So from a performance point, so in terms of the execution of, for example, change of direction task, avoiding their opponents, what might be the defining characteristic there? Okay. We've got explosive speed. We've got change of direction. We've got power. Okay. We've got the strategy used. So I'll jump ahead here, and the answer might be something like this. It's how safely or not they're able to use their brakes. That arguably, and what we're saying is here, this idea that raw speed as an athlete, you need that. In this case, the ability to slow down, to decelerate safely, has a lot to do with ACL injury risk. Okay, The idea being that raw speed, if you can't control that speed and decelerate in a safe way, either from a performance point of view, so you can run as fast as you like in straight lines, but if you're not able to decelerate that safely and then re-accelerate powerfully again to either follow an opponent or avoid an opponent, then you're next to useless on a field-based sport or a court-based sport. So the ability to decelerate, arguably, remember we're thinking knee injury risk here, is arguably perhaps the single most important quality that you need to have. Literally, speed can kill when it comes to injuring your ACL. It's how you manage and control that speed. So let me show you some examples now. So I'm going to show you some images here. Your question is, again, biomech people, you probably have an advantage. If you've got a non-biomech person next to you, have a chat to them and help them here. I'm going to show some injury videos now and see if you can spot any differences there. So why did the following athletes rupture their ACL? Now, these are potentially distressing videos for that athlete personally. This is, as I said, a devastating injury. Here's in AFL. This last here, first touch, first ever professional game. First game, very, very first touch. You'll probably see a better view in a minute. There's some audio there that we're not hearing, sorry. Now watch this carefully here. So it's a change of direction maneuver here. We know with ASO, the different situational patterns are, change of direction is one. Here's a two-dimensional image here. Okay, think about things like angle of the trunk, position of the knee, foot position, and these sort of things. Your anatomy studies here become really important. Okay. Any comments there? I'll show you one more. Here's more what in situational pattern, a defensive press. This time we have I've forgotten her name. Erin, I've got a name, who's now applying a defensive press to an opponent with the ball, goes to chase, goes to follow her. Boom. And down she goes. So here's the 2D grab there. Obviously, 2D shots are giving us a very limited point of reference here, but there's some key things that I'll talk about shortly. Okay. Think about angles and relate those angles to the anatomy of the knee particularly, and think about kinetics and kinematics and forces. And remember, physics is what? It's how stuff happens, isn't it? Biomechanics, it's explaining how stuff happens in the context of human movement and movement of other things too. This one here's a bit different. I know netball's a foreign sport for you guys here, but this is probably the dominant female women's sport in Australia. All right, become a bit more clear shortly. So there's your 2D grab there. One consistent one, again, I'm trying to read the room here a bit. Who knows a bit about the anatomy of the knee? So Carla, question? Sorry? I didn't know if you were asking now. Yeah, I'm not really helping it, am I? So who's done a bit of an anatomy study here? Yeah, so I had a bit of an assumption that perhaps there'd be a bit more kind of anatomy and functional anatomy out there. So I'm probably being unkind to lots of you here. All right. Okay, so Carla, what do you think?
Sorry, I jumped the gun.
No, not at all. Not at all.
Okay, it seems like all those videos had like hip abduction and knee internal. rotation. Like it was a step that was maybe further than they intended when they were trying to do the directional change.
I'm going to challenge you on that last point that there's hip abduction. So you're saying hip or knee abduction? Hip, so okay, which is different from knee abduction, isn't it? Because that whole valgus thing crops up, that knee valgus as a dominant component. But you're dead right. Yep. So hip abduction becomes important here. Any other thoughts there, Walter?
Straight legs. They all have straight legs.
The knee's straight, isn't it? Does anyone know why that's important when it comes to the ACL? It's actually really, really important when it comes to the ACL. Okay, I'll come to that, but remember that Walter's point about knee angle or the how close to full extension the knees is a super, super important point. This one's a bit different. This is another AFL plague, another view here, quite different from the earlier, but it's kind of but another situation is kind of landing from a jump. And this was actually the injury that ended this player's career. Didn't play again. Boom. Okay. So what we're saying is here, this is a bit different. So unlike that kind of more controlled change, kind of planned change of direction, defensive press, this is all about chaos. This is just stuff that's really that's where preventing this kind of injury is virtually impossible. Okay. But begs the question. So that's Chris Judd ruptured his ACL there. Watch this. What about Con O'Callaghan? Different sport again. Gets up, kicks a goal in your face. So he did exactly the same thing apparently that Chris Judd did, even worse, bounced up. See you later, folks, I'm off. And by the way, eat my dirt. Okay, so there's a great example there. Seemingly the same mechanism. So why did Chris Judd's knee fail and Con O'Callaghan gets up and makes his opponents look like fools? Anyway, let's try to answer that now. Okay, so we'll walk through some risk factors for ACL injury here. Okay, and again, we've got a bit of a biomechanical focus in here. But any questions at this point? A few of you might be out of your comfort zone here saying anatomy, pathoanatomy, kinesiology. I get that. But I want to talk about kind of modifiable and non-modifiable risk factors. So importantly, there's a lot of non-modifiable ones, a lot of anatomical factors here. The morphology of your knee is hugely important here. The shape and structure of the interior of your knee is hugely important. Femoral notch width index is hugely important. Gender is a hugely important one. With that, there's some kind of developmental and hormonal things in. And there's arguably a bit of a modifiable component in there, but certainly at the moment, in the sense of the moment in time injury, you can't do much about that. But certainly who your parents are can be important here. And we've got some twin studies showing fairly clearly that injury rates, ACL injury is possibly, that up to about approaching a 69% contribution to your injury risk profile, just based upon who your folks are. So to an extent, if you rupture your ACL, you can kind of blame your parents to an extent. It's a bit simplistic, of course, but what about modifiable factors? Now, this is the kind of clinically important bit, because I think, as I know Carla knows, because she's done lots and lots of testing in this space, it's the modifiable things that you can screen for and look for, and the biomechanical things, neuromuscular things, that you can, if you can identify them, you can maybe therefore inform strategies from a preventative rehab perspective, and certainly post-injury from a rehab perspective, to try to iron those out. Okay, so explore those. And here's where perhaps your biomechanics becomes important here. Now, again, probably a bit unfair if you don't understand the ACL, but one, I think, key thing that clinicians and S&C folks perhaps don't appreciate sufficiently when it comes to the ACL, it has a role in providing stability in the knee in all three planes. If you think back to your basic you'll recall sagittal plane, frontal plane, transverse plane. The ACL has a role in each of those three. Okay, so keep that thought in the back of your mind. Importantly, if we're talking knee straightening and bending, there's the ACL is never, there's two bands of the ACL, but it's never fully lax. It always has some measure of tension on it. And I think Walter made the point too. Well, who can get in? Well, think back to what Walter was saying before. In what position of the knee do you reckon the ACL is most maximally taut? Jackie? Extension. So that first 30 degrees of flexion extension is all important. And that as a variable by itself is huge. Okay. So again, think back to those videos. All three of them were marked by their knee at that moment, that final step. Each of those athletes, their knee was in or close to full extension. So at that point, the ACL is almost maximally taut. Okay, all right. Okay, so what we talk here about there being biomechanical modifiable factors, primary, secondary, there being neuromuscular factors, they are also modifiable, and also the whole cluster of importantly neurocognitive factors too. Okay, I won't go into neurocognitive too much, other than to say dancers. We've got soccer players here, NFL players, basketball players, still quite unsatisfactorily high rates of ACL injury, but we've got dancers over here who get relatively very, very few ACL injuries. What do you reckon might explain that? Potential reasons why court sports, field sports here, high rates of ACL, dancers here. And the hint there lies in neurocognitive. What's the defining difference between those, arguably? Any thought there?
One is very predictable, you rehearse it. The other one is
Spot on. Your name, sorry?
Jean.
Jean. Jean's absolutely spot on. Most dance, there'll be very interpretive dance, but different. Highly practiced, rehearsed, repeated. You're trying to replicate that pattern as rehearsed. You saw on a playing field, I think about your own experience, how predictable are your movements on a playing field? Whether you're offense, defense, that very nature of sport is it's not. What we're seeing in the ACL injury space is this recognition that open task versus kind of closed plan task is really important here. And this is actually really important in the context of screening, where often we're doing screening tests. And Carly, you might want to comment here, given some of the testing you've done, or I might even ask you what you think about what I'm going to do we agree that a lot of the screening tests, like these hopping tests, drop landing tests, are they open or closed tasks? If we're doing, say, a triple hop for distance or a double or single leg drop landing or a counter movement jump test, open or closed? Very closed. So in that sense, and we also know, well, the screening tests that we do kind of to predict injury risk aren't very good. They're quite blunt, and maybe a reason for that might be they simply don't reflect the nature or demand of what happens on a playing field, that unpredictable nature. So both in terms of testing and certainly from a rehab or prehab perspective, what we're seeing here is the need to make sure that if we're doing jump training, landing training, deceleration, change of direction training, you must introduce an unplanned open component to it, where your athlete is becoming accustomed to the idea of moving in a safe way, whilst also being exposed to cognitive challenges, be it visual, verbal challenges, if you're in it. So I might just, that's a bit of an aside. But let's drill down now into primary and secondary biomechanical risk factors. We'll go through them, and then we'll kind of finish here. So think back to the videos that we saw. First and biggest kind of modifiable risk factor is simply the ground reaction force, and both the magnitude and the direction of it. Okay. Remember, the bigger the ground reaction force, well, again, bigger the ground reaction force, then the bigger your braking force. You know, we said before, the brakes are pretty important, aren't they? We agreed that your ability to apply the brakes safely was a huge determinant here. So the bigger the ground reaction force, be it vertical, horizontal, or combinations of, then the bigger your braking force needs to be. And if you're not able to apply those brakes safely, then anyway, this idea, this axial compressive force in the context of the knee is hugely important, of course, too. And these two kind of go hand in hand. But if we think about the anatomy and morphology of your knee, the bigger the ground reaction force, the bigger the axial compression force through that knee will be too. That's a bit like, well, duh, Evan, of course it will. But this actually where it kind of starts to tie into the position of your knee, straighter versus bent, becomes important here. And we made the point, so I'll come back to that, but last key point there, deceleration, applying the brakes, has a really, really large horizontal ground reaction force. And if, say, there's a really big horizontal ground reaction force and maybe also a very big vertical ground reaction force, who can tell me here, Bimex folks, this should be easy. In terms of the knee joint, what is that horizontal ground reaction force trying to do to your knee? What's it wanting to do? Rotating which plane?
Clockwise.
Which actually will be in the sagittal plane, and those that recall, knee joint, it's a compound condylar joint, 2 degrees of freedom, but it's trying to bend your knee, isn't it? Remember, you're trying to brake though, so what has to oppose that? You need a really, really, well, there's a big external flexion moment happening at your knee. Who opposes that? Who's going to oppose that really, really powerful external flexion moment at your knee? Think about the anatomy of your knee. Quadriceps will. So that needs a really, really powerful internal knee extension moment to oppose that. Okay. So remember that. Okay. All right. So I might just scoot past this just because, again, I've kind of not misread, but a bit misinformed about who I'll be talking to today. This is a really, well, I'll touch on it briefly. This is a really bit of a landmark paper for ACL injury. And it's kind of tied into what we've been talking about, this idea there being kind of provocative and safe positions of your knee when you do things like change of direction, defensive press, landing, or combinations of those. And this idea being that your tibial plateau angle during that final step, and the final step here being, so if I'm trying to change direction, I'm running maybe toward my right, want to change towards my left, my final step with my right that I push off with to either avoid an opponent here or chase an opponent going that way, that the angle of your knee joint at that point becomes hugely important. And that the steeper your tibial plateau angle is, And this is actually independent of the angle of your knee. We're still saying that knee flexion is still important, but tibial plateau angle is really, really important, because if you think about the kinematics of this, which of these two is more likely to favour anterior translation of the distal femur on the tibia underneath? It will be this one here. It will aggressively favour, and there's other things about the morphology of your knee that don't help here as well. And this has implication too, in terms of what the foot and ankle do, and we'll come back to that in a minute here as well. Okay. But this study found significant, in terms of examples of those who ruptured their ACL versus populations that did not, found a significant difference in tibial plateau angle and what they call the limb angle, giving a total 30-degree difference between the two. Okay. Anyway, for those that do or are interested, this is a really, and Carla, have you read this one? So I keep picking on Carla. Carla's the only one I know who actually has worked a lot with ACL. So my apologies, Carla. I'm not trying to shine a spotlight on you. I'm just trying to find friends in the room. Anyway, so, but I would encourage, it'd be a really interesting one. Though probably, Carla, have you moved on from ACL maybe now?
It's been a bit. I'm more like the primary prevention side of it too.
Yeah. Sorry, yeah.
That's okay.
But I'm just thinking back to, I'm just aware that you did lots of ACL testing with one of your anyway, I'll leave you alone now. Okay, come back to that. And our anterior tibial shear is the other thing. Remember what we said, when you've got big ground reaction forces at your knee, forces that want to bend your knee, there's a really big force to oppose that, and that's what we might kind of colloquially call your quads force. So that's the magnitude of that internal extensor moment, by its very nature, can place really, really high strain on the ACL in the sagittal plane. Now, next video might freak you out. Remember, hold here too as we go through. Keep in mind it all. I did say, what about the ACL? It provides stability in what? All three planes. So take note of that right-hand bit as we go through, and you'll note how we've got different factors playing out in all three planes. Okay. Hop. Okay. So what's happening there? Now, this dude, now probably, can I just say, possibly some numpty physio or S&C person may have prescribed that. Now, sorry, I'll pause there. You're seeing an ACL rupture happening. You're seeing the ACL rupture and the tibia being released to collapse forward relative to the distal femur. Now, the point of that video is to illustrate how powerful the quads force can be. That you fire up the quads powerfully enough and get the right direction angle, it can actually rupture the ACL by itself. Have you ever seen awesomeness like this go wrong? I'm awesome, and I've just ruptured my ACL. Looked like a pretty trivial movement, didn't it? In essence, what's happening there is massive contraction during his awesomeness, sufficient quads force to rupture his ACL. Point there simply to reinforce that anterior tibial shear force by itself, in that uniplanar stress, no other stresses happening, was sufficient to rupture your ACL. Okay, and that's independent of other things here as well. Now, other primary biomechanical risk factors, what your center of mass does, and anyone should be able to kind of picture this. Back to what we saw in those videos earlier. What were those athletes doing? For example, as Erin's name heard, that defensive press came in, was she Was she really well forward in her approach, or was she leaning way back? Was there one video that, the very first video, Kate Sheehan, as she pushed off, was her trunk centered, or was it leaning toward center of mass, moving ipsilaterally towards her injured leg? Think back to them and think about that Chris Judd video, that kind of chaotic landing. Where was his trunk? Way over here. So simple vectors here would tell us that if your center of mass is very high and or posterior and or lateralized in so we got both sagittal plane effects here, coronal plane effects there, and thinking about levers here, simple physics, levers and so on. So if my knee is down here and I have a big lateral flexion tip here, what will be the effect at my knee? Biomet people, what will be the effect of that?
It's going to want to rotate your knee. It produces a moment to both the knee.
Going to want to rotate your knee in the frontal plane. Make it. Does your knee bend that way? No, it doesn't. But you're going to create a really, really large abduction moment at your knee. Anyway, so you're getting, so Pidgey, center of mass displacement by itself can really dial up sagittal and coronal plane stress in your knee. And remember we said ACL provides stability in all three planes. Well, you might be getting a big impulse in both the sagittal and coronal plane just by virtue of that. And that's completely independent of what your quads are doing or what that ground reaction for force was. That you might create enough load through the ACL with enough center of mass displacement to challenge the ability of your ACL. Okay. All right. Again, and that can play out in all three planes. All right. Then we get to secondary biomechanical risk factors, and we kind of touched upon these. And we know that things like the amount of knee valgus. We mentioned lateral trunk motion earlier, trunk rotation in the sagittal plane, hugely important. We've mentioned knee flexion angle. We've touched upon tibial rotation, foot strike pattern. And just very quickly here, what we're saying here is, if we're looking at an athlete when they change direction and or land and or do something on a playing field, we're looking for, in a sense, how many other secondary biomechanical risk factors can we see? And even with two-dimensional tests, even with a digital video camera of you looking at your athlete doing things, you can get a really good sense of these things. And Thomas Dos Santos, for example, is doing this really kind of lovely tool using two-dimensional imaging where you can kind of interpret that, but accumulate a sense of how many biomechanical risk factors are present or not. So what we're saying is here, that actual knee valgus present, yes or no, magnitude of is important. If we maybe overlay trunk, ipsilateral trunk, lateral flexion on top, like we talked about before, if we maybe have an element of ipsilateral trunk rotation towards, if I'm pushing off here, I'm trying to do a change of direction this way, and I'm facing the direction and not facing the direction I want to head to, that represents a biomechanical risk factor. We've already mentioned the significance of the angle of your knee, and that anything less than 30 degrees, by its very nature, you're going to have relatively increasing tautness in your ACL. Have your knee bent 30 degrees, and that can have a protective effect by itself. Tibial rotation in the transverse plane. If you weren't aware, the ACL has a role in both preventing excessive tibial external and also tibial internal rotation also. So foot position becomes important here. And whether you have a heel strike or not. Who can spot the big difference here? If I'm trying to change the direction, if I have a heel strike versus a 4-foot kind of stripe pattern. What's the importance of that? If I do a small dance for you here, if I have a push off like that versus that, so you get the idea. What's the difference there? Two things. It has implications in terms of the angle of your knee. So note straight away here, muscle physiologists in the room, if I have my 4-foot engaged, which muscle group can I now harness? Oh, sorry, I thought you were saying that.
No.
So which muscle can I now recruit and activate and harness if I have a 4-foot strategy rather than a heel strike one? Plantar flexors working eccentrically. And with the thought being here that that's kind of the idea that your calf muscles can almost act like an airbag and have a dampening effect in terms of the impulse at your knee. That makes sense? All right, so we asked that question, what does deceleration have to do with ACL injury? And we agreed a lot. The ability to apply your brakes safely or not is what we've been talking about. So in summary, what we're saying, and we might probably finish at this point, pathomechanics of ACL, we've made the point here that if we have potentially a cluster of primary biomechanical risk factor and then add maybe a cluster of secondary biomechanical risk factors, that your risk of injury will be dialed up. And what we're saying is here, the thought being that your non-contact ACL injury, probably typically from a biomechanical perspective, recognizing web of determinants, complex, remember Sam Kerr, thousands of times done that. Why did her ACL fail? But if we think kind of biomechanics, that non-contact probably represents an accumulation of biomechanical risk factors and other factors too. And that the knee is probably very capable of coping with an accumulation of perhaps 1, 2, 3, even in some cases 4 or more factors. But the thought being that the more risk factors you accumulate will progressively dial up the load on your ACL. And at some point, your ACL will fail. With that being, and the more risk factors you have present at the moment of that final step, that's when you win the prize, and sadly you end up with an ACL injury. Okay, and that would obviously be quite variable from person to person. Remember Conor O'Callaghan, the Gaelic football player, probably just one who can cope with a very, very large number at that point in time. Okay, and that's where I might just finish there and give you a chance to ask some questions. Before I do, who teaches here? I know I asked that question before. What I want to know from you, what's the best ever excuse you had for a student missing one of your classes? Had some doozies out there? Some kind of, no? All right, my best ever excuse was this one here. So when Craig Adams won the Stanley Cup, his brother, who was studying at Curtin at the time, because am I right here that when you win the Stanley Cup, each player gets to take the cup home for 24 hours and show the family? And so he flew all the way home from Western Australia to spend the day with his brother who just won, and he emailed that through. I thought that was an absolute blast. Guys, thank you. I'm done. I'm hoping even for those folks that don't know, that's not your comfortable zone, that kind of made some sense. But please, any questions or queries or thoughts?
As far as I know, and you correct me if I'm wrong on this, but ACL injury occurrence dominates in the second half of sporting matches typically. Is that
So
correct?
are you asking whether fatigue can be?
Yeah, not physiological fatigue, material fatigue.
Well, there's both. Yeah. The thought being one of the whole reasons when we do strength and conditioning, and I'm not quite answering your question, but sure, when you train hard to get fitter and stronger, you're training systems, different energy systems, but you're also building capacity, building tissue tolerance, aren't you? It's actually a really good question. I'm not aware of, and I could be wrong here, whether we know that mechanically tolerance of the ACL, and it probably the face validity of that makes some sense, that if you've been loading your ACL for 60, 90 minutes, that may be a factor. Let me ask you though, do you think if we were to place that element in kind of what weighting would you give it in terms of?
Pretty low. That's the structural factors.
I reckon there's a PhD study for you just there. Yeah.
I don't need another one.
Don't need another one. Yeah, fair enough. It's a really good question. Does anyone have any thoughts there? Who there's some tissue mechanics folks here?
I don't know so much about some of the Australian sports, but for sure in terms of the NFL, they do not happen during the second half of the game. They happen much earlier on. Yeah.
Now, and my other response was certainly for my. It's actually they tend to happen earlier in the game. Relative, can they happen at any point in the game? Yeah, they can. But I think predominantly we see more first half. And I'm trying to think why that might be. I should have an answer. Do you have any?
Well, you had a suggestion about the about the extension moment being an important factor, and so that's when people are most explosive. They're strong.
Because why is that? So why are they more explosive in the first half?
I think because they're fresh. Right?
So therefore, and we do know that's perhaps where if you're more fatigued, second half of the game, you're running out of gas, running on tired legs. You're not going to be generating the same forces. So, but it's a really interesting question. But I think perhaps the physiological fatigue is perhaps going to kick in earlier and dominate. Well, but certainly, could you get cyclic loading to failure? Of course you can. Of course you can. So it's a really good point. Thank you. Yeah. What's that?
Just to quickly follow up, I think in downhill skiing, it has been shown that it happens more towards in the second half of a race.
Okay.
That people get injured compared to the first.
Do you have a thought as to why that might be?
The idea always was, well, in downhill skiing, I guess you have an injury when you make a mistake. I guess when you're more tired in the second half, you're more likely to catch an edge or do something else.
Okay, so that's kind of where fatigue in this case might be unhelpful. Yeah.
So that you kind of lose control.
Yeah.
You still need the great forces and everything, but you are fatigued, you're more likely to make an error.
So we're happy that perhaps we're making that downhill skiing probably different from court and field sports in the sense of that you don't want to be skiing on tired legs because you're more likely to kind of create chaos in terms of your environment, or that mistake that you don't want. Yeah, is that what you're saying?
That's kind of the thing.
Yeah. Thank you. Yeah.
The other thing about downhill skiing is when you showed the person with the exercise leaning backwards.
Yeah.
Then,
That
injury occurs in downhill skiers, and it never occurred when I was a kid. The reason why it started occurring is because then they started, we skied in these leather boots that went to here, but when you have these stiff boots that go up to here, you are in position when you land from the jump in the backward position. Because
your ability.
They can do it because of leverage.
Yeah.
That's when they tear the ACL exactly.
Yeah.
Like that
so perhaps to paraphrase that in part, if your ankle's locked your ability to, with two things there, it's going to channel load towards your knee, and you won't be able to get that kind of airbag effect from around the ankle. That impulse is going to be channeled towards your knee. Yeah. Thank you. Any other comments there, thoughts, questions? Sorry.
We also have some undergrads here who are new this term, so feel free to also ask questions.
Did I see a hand up? Sorry, yes, please.
I have because you said this would be a talk that you present to new physiotherapy students.
Postgraduate physios, yeah.
And you were talking about, the BS meter.
You've spotted some? You've spotted some
my
BS in there?
Is actually like when they come in, I'm assuming they have come in with some preconceived notions about or the etiology of ACL injury.
Yep.
I'm just wondering, like what kind of those, what do they come into the class thinking that the cause of ACL injury?
Probably the ACL. The lack of bone perhaps stems more from. I say that example about the sacroiliac joint is much more perhaps in the pain science space, where PT is working. And my colleague, would you agree there? That's kind of much more about patients presenting to your clinic in pain. I've got posterior hip pain, back pain, leg pain, and you're trying to diagnose the source and then offer treatment. So my point there is simply when it comes to ACL, for me in terms of teaching postgrads, is that they perhaps never really learnt at an undergraduate level to understand perhaps things like the fact that the ACL actually has a role critical in all. It has a multiplanar role. So perhaps it's much more about me, well, not me, but perhaps folks like myself, perhaps adding layers of understanding. Because often they'll come in and say, if I ask them at the beginning, okay, what's the role of the ACL? They'll say, okay, it's to prevent excessive translation of the tibia. Because they know how to do a Lockman's test or an anterior draw. Often what they don't get is the fact, it actually has a really important role in the transverse plane and a really important role in the frontal plane and all these. Yeah, so does that kind of answer your question? So it's more about perhaps coming in with a pretty relatively, depending where they come from, a relatively thinner understanding, incomplete. But as when you've been an undergrad yourself, your brain can only take in so much complexity at that point. And that's why you guys are all back doing postgrad stuff. And you're at a point now as an adult learner where your ability to think at a higher level, more complex level has developed by virtue of all the hard yards you did back downstream, upstream or down. Anyway, you get the idea. Yeah.
So when you're talking about like the open versus closed, so is it possible to train people, or is there any study showing that it's effective to train people to land safer?
Absolutely, yeah. So again, so a major focus is and we've got at a primary prevention, we've got kind of things like the different sports have primary injury prevention programs. Who played soccer here and did the FIFA 11 plus as part of your warm-up, cool down, adherence and but pretty much all sports actually have a kind of preventative programs in there. But to perhaps answer your question, certainly at a semi-professional and professional level, most definitely. That's kind of where that between primary and secondary prevention comes in, where as an S&C person, like a kinesiologist or a physio like me, or in Australia, and what we call an AEP might be doing lots of screening, all these kind of testing of how they land and using those. Finally go, okay, right, you actually have a really big issue controlling what your trunk does in the frontal plane and implementing drills to try to iron that kink out. And obviously from a motor learning, endlessly repeating it So what was perhaps that felt like an unnatural pattern becomes an entirely normal way for them to actually move. And if you're asking, do you then maybe add layers of kind of an open component? You absolutely do. Like in most professional sports now, when they're doing their primary injury prevention stuff, they will dial it up to include visual prompts, so these unpredictable tasks. And you might have some kind of unpredictable visual prompt or a verbal prompt, or you might be given a cognitive task to kind of process. So that's kind of where increasingly we're kind of heading. So at a professional level, does that work at kind of more of an amateur level community sport where you're not a full-time athlete? But that's where we think things like primary prevention programs like the FIFA 11 plus in particular have been shown to reduce injury incidents substantially. But the big variable there is compliance. You've got to keep doing it. You can't do your FIFA 11 plus in last season and expect those effects to translate. That's kind of where kind of broader strength and conditioning comes in. If you don't do the hard yards in the gym this year that you did last year, well, then don't be surprised if you blow a hamstring this year or whatever. Does that make sense? Yeah. Thank you.
So if you have an athlete with an ACL injury, what criteria do you apply when they are back, when you think they are ready to go back to competitive sport?
Oh, how long have you got, Walter? So look, it's a really, really important question. The short answer is increasingly when it comes to rehab, so that kind of tertiary prevention space, we for different injury types, and certainly ACL, we very much kind of use a KPI informed approach where there'll be stages of injury or stages of rehab, and there'll be kind of key performance indicators for each that you cannot graduate to the next stage of rehab. You can't start doing straight line running here until you've ticked off these KPIs here. You can't start doing plyometric and offline running until you've clearly achieved consistently KPIs to graduate from that stage. And in each stage, there'll be really kind of, depending on, it'll vary a bit from sport to sport, but there'll often be batteries of tests.
Let's say soccer. I have an injury.
Yep.
I think I'm ready to go back to competitive play.
Yeah.
What will you do?
Yeah. So
Walter
Walter sustains an ACL injury. You're 9 to 12 months down the track, and we're kind of going, Walter. Bear in mind, a key question would be, Walter, do you personally feel ready to return to sport?
Yes.
You do. Okay. Well, that's fine. You might feel ready, but in order to do that, what we're saying is that psychological readiness to return is often the biggest barrier. And I forget the NBA player who, and I might come back to the NBA, but perhaps answer your question. Depending on the sport, there will be a really robust cluster of standardized tests. For example, the back in action cluster that was developed by one of our colleagues in Perth has a battery of kind of single leg hopping tests, kind of tests of kind of on-field skills. There's both a quantitative performance component. There'll be a qualitative component in terms of how you exercise that skill. And there'll be other kind of performance, like kind of reactive strength indexes, these kinds of things. But the key thing, there'll be a battery of tests that even though you told me, Evan, I'm ready to go, I'm ready to play. But if you did not pass all those tests, I'd be saying, look, sorry, Walter, can we sit down and have a chat here? And myself and the S&C or whoever and coach will go, look, well, in actual fact, you've still got work to do. Though often there's situations where you might have an athlete who ticks off all the strength tests, the hopping tests, the quality of execution, open tasks, closed tasks, but who says, look, it seems like I get that, I can see I've done it, I just don't feel ready to go out and play. And there's quite a number of kind of well-known athletes, and I forget who the NBA player was, who I think within 9 months was consistently achieving every KPI, but did not feel psychologically ready for another 12 months after that. He got back to playing and is now still playing. But that was fundamentally, for whatever reason, and that's kind of, again, where the kind of complexity around, we are not just tissues and bones, are we? There's that ankle, knee is actually attached to a person, and that person has cognitions and thoughts and emotions and feelings and so on, which are very, that's the point being, there's often layers of complexity there. Does that answer your
Yeah, I was just looking around
question?
because one of our faculty members does that type of work and he's not here, so I wanted to have.
Yeah, I thought there'd be a few more folks. Sorry, you're pointing at me?
There's a question online.
Oh, sure. Are we? It's 4:15 though. Are we still? Do we need to close up? But I'm happy to take it.
Well, there's a question from the audience that say, does the PCL also have a multi-planet role in the
Yes,
field?
it does, and it's almost the mirror image of the ACL in all 3 planes. Yeah. So they have a very complementary action, but in essence, they're almost the mirror image in terms of their function. So they're therefore injury mechanisms will be different between the two. Is that an okay answer?
I'm waiting for the answer.
Yeah.
Well, we'll wrap up there and we'll thank